Welcome to GN10, a bite-sized podcast brought to you by the International Society of Glomerular Disease. Our hosts are nephrologists and glomerular disease experts, Dr. Kanar Jabari of Northwell Health and Hofstra University on Long Island, New York, and Dr. Koil Jain from the University of North Carolina, Chapel Hill.
Hi, everybody. Welcome to this special episode of GN10 with your co-hosts, Kanar Jabari and Koil Jain. We are so lucky and privileged to have Dr. Anna Burgner with us joining today. Dr. Burgner is the Nephrology Fellowship Program Director at Vanderbilt. Thank you so much for joining us.
I'm so happy to be here. Thank you for having me.
Of course. Do you mind telling our listeners a little bit about yourself?
Well, also, Koil, you want to tell them that this is a NephMadness episode, right? This is a special month.
Oh, yes. Dr. Jabari has let the cat out of the bag. That's the saying, right? I always get the sayings wrong.
No, you could change the animal if you want. Some people are dog lovers. It's okay.
Sounds good. Yes, this is a special NephMadness episode. For people who do not know this, Dr. Burgner is the one who came up with the name GN10 in one of our ISGD meetings. So Dr. Burgner, tell us about yourself.
So I'm a NephMadness executive member, which means that every year I get to help design NephMadness for the whole entire world to enjoy. I am, as you said, the program director for the Nephrology Fellowship Program at Vanderbilt. I have a huge interest in education. And another one of my big clinical interests is in women's health nephrology, where I see a good portion of pregnant women with CKD in my clinic at Vanderbilt.
It's good to see NephMadness enter its 11th year, correct?
12.
12. Oh, wow. I still remember the call I got when I was the AJKD blog editor on that December about doing this. And I'm like, are you kidding me? It's going to really work. And it did. And it was just amazing to have this now flourish for so many years.
Yes, it's such an exciting month, the month of March, thanks to the great brain power and idea from Matt Sparks and Joel Toft to get this going.
I entered the NephMadness game a little bit late and really had a hard time wrapping my head around themes, concepts. I finally understand it, but I'm sure there's some listeners who may not know.
It took an hour of tutorial yesterday.
In all honesty, I called Dr. Jabari yesterday and I said, can you please tell me a little bit more about NephMadness in the sense, how do we decide as to what wins?
It's a struggle because a lot of people are not basketball fans, right? So NephMadness was based upon the US's NCAA March Madness. And if you don't have a good understanding of what that basketball tournament is, it can be daunting to try to begin to understand what NephMadness is. But basically, every year what we do is we choose hot, exciting, new things going on in the nephrology world, different topics. And we create educational scouting reports, so to speak, about each of these topics. And they're really just short evidence-based reviews, which we release to the public March 1st for everyone to be able to read and think about which topic is really the most important, what's going to be the most important in nephrology over the next 5 years. And we have a blue ribbon panel that actually decides which topic wins. There are 9 nephrologists from around the world, and they have such a huge undertaking of having to decide who wins NephMadness every year. And they have to have very thick skin because a lot of people don't end up agreeing with their choice.
You know, there are copycats. There's Onc Madness now. There's Hep Madness. There's Room Madness. Yeah. NephMadness was the first one.
We were the first. Yep.
And we actually have a NephMadness party. 2 of our faculty members get everybody together, fellows together, and we all decide on brackets and put in a UNC bracket. We haven't won that yet. It's exciting.
If you are new to NephMadness and haven't participated before, the first step is to go to ajkdblog.org. During the month of March, the AJKD blog site completely transforms to be all NephMadness. So it's a great place to start to read the scouting reports, check out what the bracket looks like. And then from there, if you go to nephmadness.com, you can input your brackets so that you have a chance of winning the glorious title of being NephMadness champion for the year.
So this category is pre-eclampsia, I understand. Yes. And you're going to tell us a little bit about this category, and then Koil and I need to figure out who's going to be the winner in this category.
In this year's preeclampsia region, we talk about the most common glomerular disorder in the world, preeclampsia, and it is certainly more than just a kidney disease, but it is a significant kidney disease as well. For those who maybe are new to preeclampsia or who try to avoid the OB ward at all cost, it's a multi-system progressive disorder defined as new onset hypertension that's accompanied either by new onset proteinuria or other end organ damage, such as thrombocytopenia, liver dysfunction, new kidney dysfunction, or new onset cerebral or visual disturbances that occur after 20 weeks gestation. It is really important for us as nephrologists to understand this because women with CKD have a very high risk of developing preeclampsia during pregnancy. And that risk increases as the degree of CKD worsens. In addition, our patients with glomerular nephritis, like lupus nephritis, have a very high risk of preeclampsia as well. So it's really important for us to be able to discuss the risk of preeclampsia with our patients and understand how to modify the risks as much as possible.
Every time you talk about the glomerulus, it excites Coyle and I. And the fact that you've mentioned this is a glomerular disease, and it's actually the most common, more than IgA, I think that's a take-home message. And it's important to OB folks to understand this is a renal disease primarily. Is it fair to say that in the current day and age, this would have been named just TMA in the pregnant patient or endothelial injury in the pregnant patient? Because back then people didn't know enough and they called it HELP syndrome and all these fancy terms. But if you look at it now, isn't this just endothelial injury?
I think you're absolutely correct, as they've renamed a lot of the TMAs already. I'm surprised this has not been renamed TMA of pregnancy origin.
So, Dr. Burgner, this is a hard ask, right? You have to figure out this is an important disease. There's two sides to this, I understand, right? The diagnosis portion of preeclampsia and then the long-term sequelae and the prevention of preeclampsia. And those are the two regions. I know you're going to ask Dr. Javeri and I to answer which one, debate about it. What is your thought?
Oh, geez, putting me on the spot. Which team should win this region? So on one hand, we have the ability to diagnose women with preeclampsia, which can be very hard in our patients with CKD, particularly if they already have hypertension and proteinuria. It can be very difficult to tease out, do they actually have preeclampsia? Is this lupus nephritis flaring? Is this something else going on? And excitingly, in the United States, for the first time, we have a test available to help us differentiate between, is this preeclampsia or something else, referring to the soluble FMS like tyrosine kinase 1 to placental growth factor ratio, or SFLT1 to placental growth factor ratio. So it's very exciting to actually have a test available to help us differentiate. And then on the other side, there is increasing knowledge about how to prevent preeclampsia and hopefully prevent the long-term sequelae that these women that develop preeclampsia are at risk for developing, which includes development of CKD and end-stage renal disease, as well as heart disease and many other things. So it's really hard for me to choose. So I'm just going to make you choose which is the most likely to win.
I like the whole concept of preeclampsia because I'm also an onconephrologist. And I remember reading the first report of Avastin or Bevacizumab-induced TMA in the kidney. They titled it Preeclampsia in a Man because the biopsy findings were exactly the same. And the pathophysiology is very similar because the vascular endothelial growth factor, VEGF, it plays a key role here, and that was inhibited. When you inhibit that, you actually get endothelial injury. It turns out that is a major player in preeclampsia. And there have even been trials where they did VEGF infusions in rats that actually helped preeclampsia. And that turned out that the reason that was happening is because you had these soluble tyrosine kinase, SFLT1, basically causing a lot of that. This ratio might be the diagnostic clue telling us if it's preeclampsia versus lupus nephritis versus just hypertension or pregnancy and not true endothelial injury. Because if it's true endothelial injury, maybe we should be doing exactly what, you should be doing, which is delivering and so forth. We're supposed to lupus nephritis, where the treatment can be started with steroids and so forth in some patients. So I think it's so key that the diagnosis is important in our pregnant patients, and we give this diagnosis early to have this test out there for us, because no proteinuria, no hematuria, nothing, not even like the high-end urinalysis scopes can tell us the difference between these two disorders. Biopsy is such a high risk in this population. And even a biopsy sometimes might show TMA and lupus too. So how are we going to know this is from preeclampsia or lupus or APLS? The biopsy is still endothelial injury, but maybe that ratio is the real clue here. Now, I don't know if this ratio is also elevated in lupus patients.
There's actually a very small study that's been done in patients with lupus. They looked at, I think it was 71 women with lupus, and they were all pregnant. They all had lupus. 41 of them had lupus that was quiescent. 15 of them had active lupus nephritis, and 15 of them had preeclampsia. And interestingly, the ratios were significantly different in this very small cohort of patients, but the sFlt1 to placental growth factor ratio was significantly higher in the woman with preeclampsia compared to the others that were studied. So certainly more study needs to be done in this area, but it does look promising.
What about CKD and dialysis? Is there clearance issues?
So there are only really case reports when it comes to dialysis patients and looking at the ratio. And the ratio actually doesn't change between pre-dialysis and post-dialysis, but the individual levels themselves of the sFlt1 and placental growth factor increase significantly when you measure them immediately post-hemodialysis. But fortunately, it's in a similar ratio as compared to pre-hemodialysis. So you don't have to worry as much about when you measure them. In CKD, there is an issue because placental growth factor is removed from the body by the kidneys. It's excreted by the kidneys. And in a small study, placental growth factor levels were able to predict early delivery due to preeclampsia in women with CKD stages 1 to 2 pretty well, but it didn't perform as well in women with CKD stages 3 to 5. And then when they looked at the soluble FLT1 to placental growth factor ratio itself, it was not able to predict the development of superimposed preeclampsia in this group.
It sounds like Dr. Javeri, Kinar, you're in the diagnosis camp.
Before you go to your side, I think the diagnosis can also become therapeutic, because the angiogenesis disbalance that you guys have now discovered in the preeclampsia world can lead to therapeutic ligands against, say, sFlt1 and really change the course of preeclampsia. So I think the diagnosis leads to therapeutics eventually in the future, so it wins.
I will say that I am so conflicted and I'm going to fail in this game because I partly agree with you. I do think diagnosis is important for treatment, but the reason I think diagnosis is important for therapeutic is because then it prevents it in the long term, and it prevents long-term sequelae, right? What is our end goal here, right? It's the end goal for every patient is not just to treat the disease, is to prevent morbidity to happen in the future. And so we keep talking about CKD population, ESRD population, hypertension in this group. We're trying to prevent all of that. So if we can treat it and we can then prevent the long-term sequelae, I think becomes really important. There was some data, Dr. Burgner, you had mentioned elsewhere, is that about 70,000 maternal deaths happen as a result of preeclampsia and 500,000 fetal deaths per year worldwide. That's a huge amount of mortality, right? How can we prevent that from happening? And I do think that I agree with you, right? Preeclampsia is a disease that affects the kidneys, right? This is a renal problem. But I do think the OBGYNs still play a huge role in diagnosing these patients and then consulting us once they sort of figure out a trigger or something's abnormal. But I do think that it's the nephrologists who really play a key role in preventing the disease from happening in the future, right? I know that we don't really have a lot of treatment options there, but we can truly prevent development of CKD, worsening hypertension in these patients, and even mortality.
So I think the diagnosis wins.
Wait, I do not think that's the conclusion we came to. I think we pretty much decided prevention of mortality, CKD, and end-stage kidney disease is really important. And diagnosis is just a stepping stone to that.
Yeah, I think if we can prevent patients from developing preeclampsia and then all of the long-term sequelae, we are decreasing the number of new patients with kidney disease and heart disease, and it's a big win. It's a big win.
Dr. Javeri, I think she just agreed with my camp.
I still think diagnosis will take the top of this. I think the blue ribbon panel will speak to my favor.
We'll find out this month of March.
Yeah, so the blue ribbon panel matchups will start being released April 2nd. So early in April, we'll start releasing the results of each of the matchups, and we will see what the blue ribbon panel picked. I do think no matter which team wins this region, that whichever team wins this region is going to the final matchup. They'll be in the final game and may win the entire NephMadness. We'll see. It's such an important area in nephrology.
There's some amazing advances in the preeclampsia treatment, or at least the hypertension component, especially the CHAP trial, right?
Yeah, it was New England Journal of Medicine in May of 2022. And it was a huge trial enrolling over 2,000 women with mild hypertension that were pregnant before the gestational age of 23 weeks to either have a goal blood pressure of less than 140/90 or only to treat if the blood pressure was over 160/100. And for the first time, we were able to see a really impressive benefit to women who were treated with a goal blood pressure of less than 140/90 with better pregnancy outcomes. And there had often been hypothesized that there would be a risk to the baby by decreasing the blood pressure. You were going to decrease blood flow to the placenta, and babies were going to be at risk for being born small for gestational age. But they did not see that increase, or they did not see an increase in the risk of small for gestational age based upon the different blood pressure goals.
Well, regardless of which camp wins, I think the category of preeclampsia should advance. That's what we're hoping for.
I 100% agree with you. Dr. Burgner, I'm so glad that you came and joined us.
Thank you so much for having me. I hope you will both submit your NephMadness brackets, and hopefully all the listeners will get their NephMadness brackets submitted as well too. Remember, you get 2 NephMadness brackets that you can submit, so you can pick both teams to win if you want to.
So basically this year, I just don't have to do it through UNC. I can do it on my own. Now
You
that I know.
can do it on your own, yeah.
Well, you were able to do this on your own. Even
I
5
know. It does. Okay, this doesn't have to be.
No, we are keeping this for sure. But I have to have the upper hand with this one.
I'm gonna pull in our producer of the podcast into this. Laurel, did you know about NephMadness, and do you submit a bracket?
I learned about NephMadness only after I became ISGD executive director, and I do submit a bracket, but I have to say that yours is probably much better informed than mine.
But you are participating. We appreciate that.
And it's a great way to learn about these exciting new advances that are being made, regardless of whether my bracket wins or not.
Can patients just worldwide, anybody can participate?
Anyone can participate, and we do have a handful of patients that participate every year. We also have people's children getting in on it to see who wins in the family. So yeah, anyone can participate.
So cool. Thank you so much, Anna.
Yeah, thank you for having me.
Of course. Thank you.
Well, this is Kenar and Coyle signing off for GN10. Till next time, thank you.
This has been GN in 10 from the International Society of Glomerular Disease. You can listen and subscribe wherever podcasts are found, and tweet at us at ISGD Tweets. Thank you for joining us.
Hi, everybody. Welcome to this GN in 10 episode, which is a very special one for your... Sorry, I'm going to say this again. Hi, everybody. Welcome to this GN in 10 episode with Dr. Anna Burgner. I should not have started. I'm going to say this again. Sorry, Laura's going to kill me. Hi, everybody. Sorry, everybody's laughing, so I'm going to say this again.
We should keep this.
Outtakes, good outtakes.